I'd like to turn over the presentation to Veronica Wagner, who will be giving the presentation today.
Good afternoon, everyone. Again, my name is Veronica Wagner. I'm Health Systems Manager here with the Alabama Medicaid Agency. Today's presentation is on participation requirements for our primary care providers and our delivering healthcare professionals. The purpose of the presentation today is to not only clarify what the agency's expectations are for our providers, or to give the providers clarification on what expectations are, but to also reiterate the importance of our participation requirements for the ACHN program. Starting out, we will discuss the qualification requirements for the ACHN participation program. If you are a current bump provider, these qualifications may look familiar, and they are. In order to participate or qualify for participation in the ACHN program, you must be board certified as an MD or DO with one of the specialties or subspecialties listed.
For children.
If you are a non-board certified provider, you must attest to at least 60% of your paid claims by Medicaid regarding the certain procedure codes. In addition to meeting qualification requirements, you must sign agreements. The first agreement you must sign with to be a Medicaid provider, which is your basic agreement. You must also sign an agreement as a Medicaid provider, primary care physician group agreement. You must sign an agreement with the entity in which you want to participate with. And it's only necessary to sign one agreement. However, that one agreement will allow you to participate with entities all across the state with the 7 different regions. This is an example of one of the participation agreements, and of course it is only the first page of that agreement. The agreement itself is several pages long. I would encourage you, if you have not taken the opportunity to sign up with an entity, please, as soon as you can, go out and reach out to the entities within your region and sign the participation agreement. But it's like certain things that we order. Additional participation requirements require the provider to actively participate with the ACHN by reviewing the care plans, participating in the multidisciplinary care team as needed, participating in quality initiatives, and also attending our medical management meetings. If you are a current health home provider, you are familiar with this requirement. However, under the ACHN, providers have the ability to allow their collaborating nurse practitioners and PAs to attend those meetings in their place. Here's an example or a chart showing the participation rates versus the current bump rate. We won't go over all of the rates, but we'll look at one example. And if I could bring your attention to procedure code 99205, it's an office visit. Under the column showing the bump rates, it is currently $194.18. Under the ACHN, that rate goes up to $210, which is a difference of $15.82. And if you look at the remaining codes, you'll notice that the amounts do increase under the ACHN. Next, here's an example of the payment chart for our PCPs actively participating and for those PCPs who decide not to participate. If I could bring your attention to PCP scenario number 3, it is regarding PCPs eligible for bump rates. However, those PCPs may not choose to participate in the ACHN. And if you go over to the categorized columns showing the different rates, you'll notice that the PCP is eligible for the bump rate. However, because that PCP is not participating in the ACHN, that PCP is not eligible for bonus payments or participation rates. There are other providers who may have the opportunity to participate. However, they will continue to receive their current fee schedule. Those providers include FQHCs, RHCs, and teaching facilities. However, if these providers choose to participate, they do have the opportunity for bonus payments, but they must actively participate, which lead us to our bonus opportunities for all actively participating providers, or PCPs. Starting with quality, we also have a cost effectiveness bonus and patient-centered medical home bonus. For the quality bonus, Medicaid will calculate a quality bonus payment based on performance, and the payments will be based only on measures relevant to that group practice. Some of those measures may include child visits, adolescent well care visits, immunization, follow-ups after the ER visits for alcohol or drugs. Next, we'll go to our cost effectiveness bonus. We have held presentations before, and we discussed the attribution process. However, I'm not going into it in detail in this presentation. Currently, we have the patient panels. Going into the ACHNs, that will no longer occur. There will be an attribution process, and cost effectiveness will be based on the patient attribution to that PCP or group. It will be a risk-adjusted payment, and that will include a 2-year look back of medical claims and a 1-year look back of medication maintenance claims. And you will be receiving this bonus on a quarterly basis. The next bonus listed is related to patient-centered medical homes. This bonus is available to qualifying providers who either show progress towards receiving or attaining recognition through one of our national agencies, which NCQA is one, or if you have attained recognition, you are eligible for this bonus. Next, we'll go into delivering healthcare professional participation, or DHCPs. The participation requirements for DHCPs is slightly different than for PCPs. For our DHCPs, in order for you to be reimbursed for services delivered to our Medicaid eligible maternity recipients, you must participate in the ACHN program. Just like the PCPs, you only have to sign one agreement with an entity. However, that one agreement will allow you to work with all 7 regions. And with that, it will allow you the ability to collaborate with care coordinators across the state, which will assess or provide you access and ease the ability for you to manage care for your recipients. This is an example of the PCP or the DHCP participation agreement, and of course, this is just the first page of that agreement. If you have not already gone out to sign up with an entity, I encourage you to do so as quickly as possible. Because again, if you will not be reimbursed for your services unless you are participating with the ACHN program. Additional participation requirements, of course, signing the agreement, participation in the development of the care plan for the recipient, and the selection and referral process. Also, if you currently work with a maternity contractor, you provide certain types of data to that contractor. You will continue to be required to provide data to the ACHN going forward. Again, continuing on with the referral process, all maternity claims will require a DHCP selection referral number. That's why it is very important for you to contact the entity and sign an agreement, and participate in the selection and referral process, because you will need the MPI number of that ACHN to file on your claims in order for you to be reimbursed for your services. In addition to that, along with PCPs, DHCPs, a list of DHCPs and PCPs will be provided to the agency on a monthly basis, which will allow us to track who is participating with the program. Here's an example of what the selection referral form looks like. It's a basic form. At the top, the entity's information will be provided, the EI's information, and then the DHCP's information following. Here's an example of some of the rates under the ACHN program for maternity care services. We will not go through all of the rates, but if I could bring your attention to procedure code 59514, which is a cesarean delivery. The current rule rate is $1,250. Under the ACHN program, that will go up to $1,340. The current urban rate is $950, and the ACHN rate will go up to $1,040. And of course, this information is available on the website, and the link will be made available at the end of this presentation. DHCPs also have the opportunity to receive bonuses. You can receive a bonus if you make the initial prenatal visit within the first trimester, and also a postpartum visit between 21 and 56 days post-delivery. Here is the map with the regions drawn out, and also next to the map you will see the contact information for the executive directors for each of the 7 entities, along with their email addresses. Again, this information is available on the website, and the link will be shown at the conclusion of the presentation. In summary, here is a graph showing the payment structure for PCPs. Again, actively participating PCPs have the opportunity to receive 3 bonus payments, 1 related to quality, 1 cost effectiveness, and 1 to PCMH activities. However, if you choose not to participate with the program, you will continue to receive your current fee schedule. A summary of the DHCP payments. Again, as a DHCP, you are required to participate with the ACHN in order to be reimbursed for your services. You have the opportunity to receive 2 bonus payments, 1 by performing a prenatal visit in the initial prenatal visit in the first trimester, and then a second visit, a postpartum visit, 21 to 56 days post-delivery. Here are the links to the website There's also a link to frequently asked questions. And if you have additional questions once the presentation is over, you may submit those questions to the email address listed here. Okay, I will open it up for questions now.
And we do want to let everyone know, please don't mute your line unless you're fixing to ask a question, but you can also add in the questions in the chat box. We are recording this, and we will be posting the slides, as well as recording on the website as soon as we can after this presentation. Going through a couple of the questions that we had previously, Veronica, is the E&M participation rate only for PCPs or for anybody?
You have to be an actively participating PCP in order to receive the participation rate for the E&M codes.
So what do I have to do to participate?
You have to sign an agreement, meet the qualifications that were listed at the beginning of the presentation.
Okay. And is the bump just for PCPs or is it for DHCPs as well?
The bump rate only pertains to PCPs.
Okay. Will the patient have to select an ACHN before seeing the DHCP?
Technically, the EI will not have to select an ACHN prior to the DHCP. However, the ACHN will work with the DHCP in order to complete the referral process.
So the EI, the recipient, could show up to the DHCP office first, but that DHCP would need to get a referral, correct?
Correct.
What will happen to the monthly capitation fee that's once they move to attribution?
The capitation fee will transition into the bonus payments, and in order to receive the bonus payments, you have to actively participate and meet all of the bonus requirements.
So the capitation case management fee that you're currently receiving, if you are a patient first provider today, you will not receive a capitation payment after the September check write. Starting October 1, there will no longer be case management capitation fees. What will you consider as a first trimester? Different payers consider different weeks of gestation. The agency has answered that question previously, and it is on the website. Our maternity expert's not here today, but we will answer that question as well. People that are already enrolled in the current program, will they have to re-enroll or will they be grandfathered in?
If you are a qualified Medicaid recipient, you will be attributed, as explained before, or the recipient of EI will be attributed.
But the care coordination they currently are receiving will not be the same. They will have to, historically for patient first, you would get, or for health homes, you would get from the health homes. They would receive new care coordination from a different entity, so that the new ACHN would have to re-enroll that person. And there also are no longer the restrictions of just having chronic conditions that the health home also has to do. How does the referral to a specialist work? We are primary care. Do we have to send a Medicaid referral when we refer to a specialist?
Yes, some specialties will still require a referral, just as they do today.
Does the hospital have to do anything? When you ask the question about the hospital, are you regarding the delivery? Until we get that response back. Do DHCP submit data to all ACHNs based on EI home address or just to one ACHN?
To the ACHN in which you are participating with, or if the EI delivered in another location, you have the ability to contact the ACHN entity in that region and work with that care coordinator.
So a recipient can go to a physician that's outside the region, but that DHCP, if it's a maternity patient, they must have be participating with the ACHN to be paid. All right. Are there any questions online? What are the bonus amounts for quality and patient-centered medical home? The agency has not released the amount of those payments yet, but will be releasing those within the next month. Those will be posted on the website under ACHN provider. How will a physician extender payments work if the collaborating physician is in the ACHN?
If you are collaborating with a actively participating PCP group, you will receive 80% of your payment currently how it is today as a nurse practitioner or a PA.
Can patients be restricted to a provider based on diagnosis? For instance, patients are only assigned to a provider if they have an HIV diagnosis. No, patients may choose to see whoever they want to for PCP. That is a federal requirement that they have to have freedom of choice. Same thing with the DHCPs. Patients have to have freedom of choice to see the providers that they choose to for primary care. NCQA recognition. Do we need to inform our ACHN that we are recognized?
Yes, you should report that information to the region entity that you're actively participating with.
How does a provider go about becoming a participant in the patient-centered medical home portion? There are different type of organizations that you can receive accreditation or recognition from. There's the NCQA program that has a PCMH recognition program, as well as the Joint Commission also has a PCMH recognition. After September 1, will the rate increases show up on our checks if we are signed up ready to go PCP?
That will occur after October 1st. You will receive or see the rate increases.
Okay. Can an RHC become a medical home? If so, how do we get the designation as a medical home for our patients? Yes, an RHC can be a PCP. They can sign up. For the PCMH recognition, though, you would have to reach out to one of the granting groups. Like we said, two of the examples are Joint Commission or NCQA, and complete their program. How often will PCPs receive the bonus payment?
The bonus payments will be distributed on a quarterly basis.
And when in the quarter will they receive the check? They will receive the check the first check write of the quarter, except for the first quarter. The first quarter of operations, so this first quarter starting in October, you will receive your bonus check in the first check write of November. Starting in January, we will get back on regular schedule, but it was some issues with us as just kind of starting. How will Medicaid determine which provider has to send the referral if there is no assigned panel?
Can you repeat the question?
How will Medicaid determine which provider has to send the referral if there is no assigned panel?
In the instance that an individual does not have, an eligible individual does not have a PCP, the entity has the ability to step in and assist with that process to not only provide a referral, but also to assist the recipient with selecting a PCP or DHCP.
As well as the recipient has the ability to choose whichever PCP that they need to. So if you were a PCP and the patient shows up to your office, you're more than welcome, as long as they have coverage, to provide care for that patient. But if you do need to send a referral to a specialist, you can submit that. There is no longer a need for a referral from a primary care to primary care since we've gotten rid of the panels. When will we get the list of which specialists will require a referral?
There will not be a specific list that says this provider requires. There will be a detailed list in the program manual, and that list is the same as it is today in Patient First. There are some providers that don't require referrals, but there are some procedure codes that will not require referrals, and then there are some things that will require referrals, and all of those details will be lined out in the program manual.
Does any of this apply to an optometrist?
No, it does not.
Will there be future webinars referencing primary care providers? I feel this one was mainly directed to delivering physicians. Actually, we did have a lot at the beginning for the primary care. Since we do have some time, we'll go over. Do you want to go do a quick summary of the early slides for those who joined late?
Okay, for PCPs, these are your qualification requirements. They are the current bump requirements. So if you are a current bump provider, you've already met these qualifications. And they will not change.
And so what does it mean to participate? What are the requirements for participation? These are the agreements that you have to sign. You have to sign up with Medicaid. You have a primary care physician group agreement that is with the Medicaid Agency. It's much like the current Patient First agreement. Then you also have to sign an agreement between the ACHN and the PCP group. So this one is where you have to work with, you can sign with all ACHNs, you can sign with just one of them, but whoever you plan on working with, you'll have to have agreement. But you only have to sign one agreement. You just have to let the other ACHNs know that you do want to work with them. And Veronica, why don't you cover what are the requirements of participation? How do we define?
Here are the participation requirements: actively working with the ACHN entity in reviewing recipient care plans, participating in the multidisciplinary care team, participating in quality initiatives, and also attending medical management meetings. I mentioned before that in our current health home program, if you are familiar with that requirement, it is similar. However, under the ACHN, nurse practitioners and physician assistants who are in an actively participating PCP group may attend these meetings in place of the PCP.
Will there be need to have a referral for emergency room or delivery?
No, there will be no need for that.
How does this work for primary care referral? Will the referral form be the same as the Patient First form we are currently using?
Question. Can you say the question again, Drew? Can you repeat the question?
How does the work for primary care referral? Will the referral form be the same as Patient First form we are using today?
The referral form will be the same. There will be some tweaks made to it, and we will be posting that on the website within the next couple of weeks.
Which specialties require referrals? We've answered that. That will be in the provider manual, which is being updated. How do we get payments for visits prior to 10/1/19 if the patient has not delivered yet for a DHCP? For these are the current maternity contractors.
If the recipient has not delivered prior to October 1st, they will receive if they deliver in October, the DHCP will receive fee for service for that payment. If they deliver in November, they will receive the participation rate.
So basically, if the woman has not delivered, but you have provided services to the woman, prenatal care visits, things like that, you would still be paid by the current maternity contractor for those services. If the woman delivers in October, you would submit that claim and be paid first from maternity contract. You would submit a fee-for-service claim to Medicaid and be paid for that. And after November 1, if she has not delivered by November 1, you would have to get a referral from the from the ACHN, and they will provide. They will work with you, but you would still submit your claim to Medicaid and be paid that way. Several PCPs in the FQHC signed up last year in ACHN. Do we have to sign up again this year? We have not released those agreements. We only started contracting with the providers the 1st of May, So you may have had to redo your patient first agreement or your health home agreement, but you had, unless you've signed agreements since May, there was no previous agreements that are for the ACHN. So you might need to check to see which agreements you signed. The bump rate is automatically done or is via the ACHN, or do we have to file any documents with the ACHN?
No, the ACHN has no responsibility for payment to the PCPs, so you would submit your claims. It will be paid through our fiscal agent.
And for your annual bump attestation, if you are required to do an annual or whatever your recertification period is, you will still have to submit that to the agency like you historically have. If we deliver a patient out of the assigned area, how do we process the claims for payment? And will the delivering doctor have to be part of the program?
If it's an emergency delivery, then the doctor would not have to be part of the program. However, if it was not an emergency, yes.
And the ACHN will not be paying, if it's for the hospital submitting the claims, there is no issue there, and that won't change. If the woman delivers out of state and is out of non-participating provider, then it would be handled just like it currently does, and it would be submitted to Medicaid for a fee-for-service. How will the 24/7 call coverage work once the panel is no longer there, and how will it be assessed for reimbursement?
You'll still be required to have the 24-hour coverage as a PCP.
The 24/7 coverage is still required, but the payment, the capitation payment will no longer be made. We are changing the way that we make payment to physicians. You'll no longer get a capitated rate monthly.
Are referrals needed for an office visit with a primary care provider?
Referrals for PCPs are no longer required.
Can you explain how payment will occur for an EI that delivers during the month of October if they previously enrolled with a maternity program but has not enrolled in a PCCME?
Deliveries for the month of October will be paid on a fee-for-service basis.
If a patient comes for an OB visit and has no referral, can we refuse care? Ideally, we would not like you to not provide care. We have worked with all the ACHNs, and the ACHNs do have the capability to provide a temporary referral via phone. So if that recipient is in the office, you can call the ACHN, and that's part of the conversation you need to have with that ACHN is how easy is it for you to receive a referral? What do you need to do? What is their process to handle those type of situations? How does it work when a patient sees several primary care? Which one would be responsible for sending the referral to the specialist?
Either PCP has the ability to submit a referral. However, the PCP who sees the recipient most frequently would be considered the primary care provider.
And if that patient has shown up and you are the one who are sending them, then you can submit the referral. It would be whoever is actually sending them over for the specialist. Will individual offices still need to send out screening letters from our list on the Medicaid site in order to assure well checks are done? How each office handles their own practice, we are working. There will be several other webinars where we talk about the data that will be provided to you. If your office currently sends out letters to try and increase your screening rates, I would encourage you to continue to do that because it will continue to work well for you to meet your quality bonuses. But it is an individual choice about each office. You can also work with the ACHNs that you're participating with to see if they can help you improve your quality measures because that is one of their responsibilities as well. When will the program manual be out?
October 1.
Will we still have the monthly list available as it is now? I'm assuming you're talking about the monthly panel report. No, you will not have a panel report anymore because we are doing away with the panels. You will receive on a quarterly basis those recipients that have been attributed to you through the attribution algorithm. Does the PCP send the referral or the ACHN?
It could be either or. If the EI has a PCP, then the PCP is the one responsible for submitting the referral. However, if the recipient does not have a PCP, then the ACHN may submit the referral.
But ideally, it should come from PCP, correct?
Correct.
If the recipient can go to multiple PCPs, who will be responsible for the EPSDT screening? How will the PCP know a recipient has been screened? The EPSDT screening will still be on the provider portal, so you can still log in and determine whether that patient has received an EPSDT screening, and would be up to any PCP who sees a patient to check that and ensure that all the EPSDT screenings have been completed. The EPSDT process has not and will not be affected by the ACHN at all. Will the ACHN make sure the patient has been seen by the PCP prior to the referral?
Well, the ACHN will work closely and do all that they can to ensure that all of the visits are being made as they need to be and that the EI has a PCP. Therefore, they will be in contact with the PCP as needed.
Will we be notified of the dates and times for the Medicaid or for the medical management meetings, or is this something that we will have to find out on our own?
The ACHN is responsible for coordinating those meetings, so they will notify the PCPs of those meetings.
Will a referral be required for walk-in or urgent care clinics?
For urgent care, a referral will not be required from PCP to PCP. So if there is a PCP that you see in an urgent care clinic, then there will be no referral required.
How do we find out when we have to fill out the forms for our bump rate? Will we be notified by Medicaid? The certification for bump rate will still remain the same, so I will refer you to our medical services group and be able to. You can always submit the questions. Veronica, if you'll go back to the slide with the email address. Any provider can always submit any questions to this email address. And the agency will put out a response at any time. All right. How will maternity patient re-enroll beginning October 1st?
Well, the ACHNs will be responsible for reaching out to those recipients to ensure that they are enrolled into the program. And we would also like for the DHCPs to work with us as well. If they show up in your offices, please contact the ACHN entities to get those recipients enrolled.
If a patient delivers in November or after, will they have to re-enroll to get the referral number?
Yes, the DHCP will need to go through the selection and referral process.
They will not have to re-enroll for Medicaid, but they will have to re-enroll for care coordination, though. Are there any plans to expedite the credentialing process and or the deadline for claim submission so that providers will have more accurate information regarding previous office visits, allowed EPSDTs, etc.? There is no plan to change the credentialing process. We try, as long as you're always more than welcome to work with your DXC provider rep to make sure you have all the paperwork taken care of. Their ACHNs are also working very diligently, working with providers, making sure they have all their paperwork taken care of. As soon as a provider submits a claim and gets processed, we try and submit. We do check writes almost every 2 weeks, so we try and process through pretty quickly. Are you going to provide the clinics with the information for the pregnant patient to get signed up with the DHCP or ACHN? Are you going to provide the clinic with the information for the pregnant patient to get signed up with the ACHN?
The ACHN will work with the DHCP. It depends on what clinic you're referring to. However, we encourage the clinics and the DHCPs to reach out to the entities in order to get the recipients enrolled as needed for care.
Let's go back to the definition of first trimester. We define first trimester as 0 weeks and 0 weeks to 13 weeks and 6/7 days, months 1 through 3, or 1 through 97 days. Will the limited amount of office visits per year stay the same, or will this change as well? It will stay the same. When patients have multiple PCPs, will the ACHN be reaching out to those patients to try and establish a stability with the PCP?
Yes, they will do their best to get the recipient to remain with one PCP at a time.
Are there any limitations for telemedicine visits? Is the overall visit limit still 14 visits per year? Yes, the 14 visits still will stay unless there's a referral through EPSCT to expand that. When billing can be delayed up to 1 year, the EPSCT information on the portal will not be accurate. We agree. Unfortunately, we have to run off of the data that we have, and if claims have not been processed or have not been submitted correctly and can't be processed, we have to rely on the information that we have. So that's why it's incumbent upon all providers to try and submit claims as timely and correctly as possible. When the portal isn't updated immediately, so how will we be able to ensure that EPSCT has already been done? The portal is updated after every check write, so after every almost 2 weeks, the portal is updated with information. Will a rural health clinic require a referral for primary care?
If the rural health clinic is a participating PCP, then no, you will not require a referral.
How it works if the portal has not been updated and we do an EPSCT screening, but the patient has already had one in that year? How will it work if the portal has not been updated and we do an EPSCT screening, but the patient has already had one in that year? We'll have to take that one back. Will there still only be 14 visits allowed 1 year? Yes. How frequently will the screening dates be updated on the portal? As soon as we receive claims that they've occurred and that after the check writes. The portal can only be updated with billing. This means that a patient can literally go to multiple PCPs several days a month. PCP will have no way of knowing recipient. And that's when we would work with the ACHN to make sure that the patient is not shopping around and blowing through their 14 office visits. That's the whole purpose of the care coordination and the ACHNs. Are webinars the only training that delivering providers will receive regarding these changes? We will be releasing a provider insider. We will be updating the provider manual with all the information, and DXC provider reps have been offered to any provider who's willing to ask them. They'll come visit you in your office to go over billing changes, go over any additional questions you might have. And you are also able to submit any questions you might have to the email address. As of now, the maternity patients in Coleman County go through the health department to get signed up. That will continue. There will be Medicaid outstation workers and still the health departments. The Medicaid eligibility workers will still stay the same. That process will still stay the same. But the ACHN will also have staff members who have been trained to help work with the recipients on completing those applications. They're called application sisters, and we encourage you to reach out to the ACHN to try and help identify those patients. So if someone does show up, they can try and help them with their application. Will the PCP or specialist have to be credentialed for all Medicaid types, i.e. full Medicaid, patient first, plan first, or will only one contract agreement cover all? If you want to be a Plan First provider, you still will have to have the separate agreements for Plan First. Patient First will cease to exist. So to be a PCP and to receive the participation rates, you must sign the new PCP group agreement with Medicaid, as well as a participation agreement with at least one ACHN and meet the participation requirements. Will ACHN care coordinators still be located at each hospital?
That will be up to the entity themselves if they choose to place a care coordinator in other facilities, that's their decision.
Will Medicaid still offer help with transportation of recipients?
Yes, the transportation program will not change, but the ACHN will assist the recipient in getting the transportation that they need.
Patients can go to more than one doctor in the same day. Who will get paid if this happens? It will, unfortunately, that can occur today, and it will be whoever submits their claim first and gets it processed first. How do we go about scheduling DHCP rep, a DXC rep to come help further training?
Contact DXC.
Is there information on the website?
There's information on the website.
All right. That's all the questions we have in the chat box. Does anyone on the phone have any questions? All right, as people are still thinking through, I do want to remind everyone that we will have webinars every Thursday from now until September 26th. There has been a slight change in the schedule, so I want to call that out to everyone's attention. The next week's presentation will be ACHN procedures. We'll go over BMI requirements, referrals, understanding the new rates, and more of the nuts and bolts for a primary care provider. Then on September 5th, we are switching it up, and we're going to have a presentation that is all about attribution, going into how we calculate attribution. Then on Thursday, September 12th, we will have paying for quality, understanding the quality measures and data availability for the ACHN program for PCPs. September 19th, we will have cost effectiveness and how the agency will calculate cost effectiveness. September 24th, DHCPs will have a presentation solely for them, all about new billing, new how to submit codes, all of the information. So a lot of the information that the provider who was asking about the DXC provider rep, you might want to pay attention for that presentation because they're providing a lot of information there. And then the last webinar on Thursday, September 26th is an open forum. It's a town hall where any questions that we have not covered, any topics that you would have questions about, any just outstanding questions, that will be your time to be able to ask whatever you would like to. I do have another question that came in. What if the patient sees primary care and specialist in the same day? Would both claims be paid?
It's a different provider type. I believe they would.
We believe they would, but we would refer you back to the provider manual for clarification.
Because if it's 2 E&M visits in one day, that would not be covered. So,
and if you go to the Medicaid website under contacts for providers, the first number is the actual address for DXC as well as provider assistance number. So that's how you can call and get an appointment with a provider rep. Are we following the ACOG guidelines for weeks gestation? We are. Can you repeat what you said about patient first going away and needing a plan first agreement? Yes. Patient first will cease to exist September 30th. There will be no more case management payments, capitation payments after September 1st. October 1, we are changing the way we pay providers. We are paying based off the participation rates, and then you will be eligible for quality bonuses if you meet all the eligibility requirements of being a participating provider. If you'll go back to the slide with the chart, if you choose to be a Plan First provider to do just the family planning services, there is a separate agreement and a separate application that you have to fill out with the agency. This payment structure is a great example, and we encourage you to go back and look at this. If you choose to be a PCP who's not eligible for bump rates and you choose not to participate with the ACHN, after October 1, all you will be eligible for is your base fee-for-service rates. If you're a PCP who's not eligible for bump rates, but you are participating with the ACHN, you could get the base fee-for-service rates as well as a participation rate for the 15 E&M codes, and you would also be eligible for bonus payments. If you're eligible for bump rates but not participating with the ACHN, all you would be eligible for is the bump rate. And if you're eligible for the bump rates and you participate for the ACHN, you would be eligible for bump rates, the participation rates for the 15 E&M codes, and your bonus payments. What is the cutoff age for pediatric clinics to get paid for seeing patients age 19? What is the cutoff age?
EPS 16 is 21. And under.
I would refer back to the provider rep. Oh, great. Tori Nix from DXC just let me know. If you are looking for a provider reps may be reached at this phone number, 855-523-9170. Thank you, Tori. There is a comment about tracking office visits. There is the ability to track the number of office visits, and the utilization is still available in the web portal.
Okay.
So when our pediatric patients go to urgent cares after hours, they no longer need a referral? This is a question. If the urgent care has enrolled as a primary care provider, no, they would not. But that would be only if the urgent care has enrolled with Medicaid as a primary care provider. Any other final questions that anyone might have?
Okay, that brings us to the conclusion of our presentation today. Again, if you have additional questions, there is a link that you may access and submit your questions, as many as you would like, and we will get back with you as quickly as possible.
We did get one final question that came in. Do we need a physician in the office seeing patients to enroll as a primary care, or would a nurse practitioner be enough?
A PCP would need to be in that group. A physician.
All right. Well, thank you, everybody, and we look forward to seeing y'all again next week for our next presentation, ACHN procedures, BMI, referrals, understanding new rates. Thank you, and have a good day.